All right, welcome everyone to our AIM game presentations for PC 730. Oh, and actually, Cara just asked if she could be invited in. So let me invite one more person really quickly before we get for real started. All right, very good. So the way this is going to work, we're going to start with each person doing their presentation. So remember, it's a 5-minute professional presentation. 5 minutes is for real. Part of the point of this session is to learn how to do a 5-minute presentation, and it's actually really, really hard. So we'll set a timer. I mean, I can totally relate to this being terribly difficult. But we're going to set a timer, and at the end of the 5 minutes, I'm actually just going to say you have to stop. So I know that's hard, but it's actually really helpful. And you know, you just have to try to stay on track so we get to hear the very end and get to hear the good stuff. Hi, Cara. Glad to have you. All right, so who would like to start off? All right, good.
I'll go.
Oh, okay, Dorcina, you got it.
All right, let me get my timer going, and then you tell me when you're ready for me to start. Oh, do you know how to screen share?
I forgot.
Okay, on the left-hand side, there's a green icon. It's a little green box with an arrow that says screen share. You'll click that.
Okay. All right, hold on.
Then share?
Yes.
1 second. I'm like trying to multitask here.
That's okay. By the time you get through with these courses, you should be really comfortable with this whole system, and then they'll likely change it like they did for the rest of it. And for those of you who are watching, if you'll click on Dorcina's name at the bottom, it will bring it up. So for a second, you were screen sharing and it went away for us.
Oh, okay, hold on. Wait, can you see anything?
Just you.
Oh dear, okay.
So double click on the green box and white arrow, and what happens when you do that?
Let's see. Screen share, okay.
Do you have the option to share your entire screen?
Yeah, it gives me the option to share my presentation. Like I have desktop and Hangouts.
So you just want to share your entire screen. Don't share application window. So there's 2 tabs usually at the top that you have the option to share your entire screen or share the various applications, and you don't want to choose that one.
So am I choosing desktop?
Desktop, yes.
Okay.
And then everyone knows you have to click on Dorcina's picture to get to see what she's sharing.
Okay, so can you see that?
Yes, so just perfect, just like that.
Okay.
All right, I'm gonna mute myself and then tell me when you're ready to start and I'll start the timer.
Okay, 2 seconds, let me breathe. Okay. Okay, I'm ready. Should I go?
Yes, go ahead and start.
Oh, okay. Hi, everybody. My name is Dorcina Gale. My AIM statement is to increase the % of obstetric clients receiving effective screening and referrals for substance use by 85% before September 15th, 2017. The problem that I am aiming to address is substance use in pregnancy with a narrowed focus on illicit substances. Currently, 43% of women who use illicit substances will continue to use them during pregnancy. Why does this matter? Newborn infants born to a mother using other substances during her pregnancy are at risk for drug withdrawal, commonly referred to as neonatal abstinence syndrome, or NAS. NAS is a variable and complex spectrum of signs of neonatal behavioral dysregulation. Over the past decade, the NAS score has quadrupled. In addition to the increase in neonatal morbidity and mortality, this has significantly increased the number of neonates admitted to the NICU. And as you can see that since 1999 till now, the incidence in infants born with NAS from 1999 till 2013 has increased quite a bit. Currently, it's now 6 per 1,000. Oops. Some expected outcomes from this project include increase in mean team efficacy score by 80%, increase in the number of OB patients utilizing concerns about treatment tool, increasing the usage of the SBIRT application, and increase in referrals for treatment from positive screens. In order to achieve the outcomes listed, I will measure staff engagement by the number of staff in service versus the number of staff on the team, measure the usage of the concerns about treatment tool by the number of tools used versus the number of patients who screen positive for substance use, measure the utilization of the SBIRT app among all new OB patients by number of OB patients screened with tool versus all OB patients, measure the utilization of the referral tracking log by number of patients logged for the ones who qualify for referrals or screen positive. Some of the initial barriers I anticipate involve team engagement, which is one of the most important barriers. My team involves the intake nurse, the referral coordinator, and myself. In time, I expect my team to expand. Doing in-services and speaking at team meetings is my initial approach to recruitment. The referral coordinator plays a significant role because this is where the biggest gap in practice lies. Another key stakeholder is the patient. Assessing the risk factors and identifying behaviors that are harmful is vital to the change. The patient will also have to be willing to participate and have the desire to change. The ultimate goal is to educate, engage, and empower both the staff and the patients. And hopefully with success, I can standardize the screening and referral process for substance use in pregnancy. Thank you.
Very nice. You had 1 minute and 30 seconds left to go. Very nice, staying on track. Who would like to go next? Stephanie, you want to go?
How do I stop? How do I stop this? Oh, okay.
You did. Good job.
Okay.
Are you guys seeing my screen? Not yet.
We were actually,
I think
we should have said that. I'm sorry. We were seeing it just not in presentation mode, and then now it is.
Okay, let me
Back to you.
change that. Sorry.
It's okay. It's okay. There are only 4 of us. We've got a minute. It's
Okay, sorry. I'm like having slight panic. Sorry.
So if you go back to that green box and double click on it, what do you see there?
Sorry about that. The green.
The green screen share on the left-hand side. Oh, there you go. Good. Now open up your presentation. Perfect. And then if you'll go to presentation mode so that it takes up.
Oh, heavens.
And you know what? If you have to present it this way, it will be okay. But I think just take a second and find it, because.
Okay, sorry. This would be terrible. Okay, I'm gonna present it like this. Can you guys see okay? Oh, yay. Okay.
Awesome.
Okay, my name is Stephanie Mitchell, and I'm going to be doing a presentation on intermittent auscultation. It's a subset of the Reducing Primary C-Section initiative sponsored by the American College of Nurse Midwives, and the bundle or area of focus that I've chosen to work on is intermittent auscultation bundle. So when we think about healthcare spending dollars, and we're thinking about, sorry, I skipped a slide. So what's my aim? My aim is to reduce the cesarean birth in the nulliparous term singleton vertex patient at Women and Infants Hospital by 3% by December 18th, 2017. And you may hear me refer to NTSV, and that's what that means. So again, when we think about the healthcare spending dollars per capita, it's a big deal because from maternal fetal outcomes in the United States being what they are, and for being what they are, the United States is still one of the poorest performing developed countries when it comes to the cesarean section rate. And approximately 1 in 3 American women will deliver by way of a C-section. The Healthy People 2020 goal is to reduce the NTSV goal to 23.9%, and the World Health Organization wants the rate to be closer to 15%. The people that we're looking at is low risk, first-time mothers, and because those are the numbers that have the greatest variation across hospitals. And continuing largely about the financial burden and implications, it's apples for apples really, because we're almost 2%, we're almost 2 times the amount of cost for a C-section delivery versus a physiologic vaginal delivery. And it's a global problem. So what we do know is that electronic fetal monitoring has an association with increased risk of C-section, instrumental delivery, maternal morbidity. And we know also that intermittent auscultation is associated with decreased cesarean birth rates and unnecessary obstetrical interventions, along with the associated sequelae that goes with that. So at Women and Infants Hospital, we can do better. We have a threshold of 33.4% NTSV rate of 18.8%, and that's according to the most recent data. And women who are eligible for intermittent auscultation aren't being monitored that way. And we found that through a chart review that 33% of the women who qualified for it didn't receive it. And those who did, some weren't it wasn't being done correctly. So what do? We want to be able to increase the amount of women who receive intermittent auscultation, because we know that women who receive it have a decreased risk of, that we spoke about earlier, of cesarean section and OB interventions. So we want to increase the amount of women who receive intermittent auscultation of all the low risk women who are eligible to have it by 30% and by December as well. And as an organic effect, really, will decrease the amount of OB interventions, ultimately decrease the amount of C-sections. The process really, it has to do with staffing. We have to be able to train staff and get them not just trained, but get them competent to be able to carry out intermittent auscultation. There's equipment issues that we need to deal with. There are patients who we can't just leave them out in the breeze. We need tools that women can use in order to be successful with the intermittent auscultation. And other things that we're going to do is increase the number of bedside handoffs using a intermittent auscultation appropriateness checklist. That's something we're going to be looking to implement over the number of admissions over a time period. Some of the balancing measures also that we're going to look at is when we're providing patients with the utilization, with the comfort kits. We want to look at, are they using it and are they satisfied? And
Stephanie, time's up.
okay, sorry. Thanks. Sorry guys, that's the end of it.
That's all right. It is very hard. All right, who's next?
Hold on.
Who was that? Was that
I'll
Audrey?
go. Yes.
Okay. I could hear the voice. I couldn't see which person it was.
Okay, so let me here. So I'm gonna open up my screen so I could share. Are you able to see?
Right
Hello?
now I see a black screen.
All
So
right.
if you go to that screen share box on the left-hand side, have you already
Let me
clicked
go
that?
back. I already clicked that. It said you are share.
Okay. It says you're sharing.
Mm-hmm. It said you are sharing screen. So I'll go back again and try that. Are you seeing anything now?
No, I'm just seeing
So
black.
This happens when you have the choice of screen sharing. There are two choices. One is to share your entire desktop and the other is to share applications. And if you select the application, you'll get a big black screen like this.
I think I thought I share entire screen. That's what I thought. So can I go back and fix anything?
Try to stop screen sharing and go back and do it again.
Okay. Hold on.
It's okay. Don't feel too pressured.
All right. Okay. So it's sharing. So that's it. That should stop it. Okay. So now I'm gonna share. So your entire screen, the blue one, is highlighted. I'm hitting share. All right. So let's try this again. See what happens. Is that any better? Hello?
Cara?
I could see it. I can see it now.
Oh, you can? Okay. So let me go back then. Are you seeing me now?
I can see it. You just need to put it in presentation mode.
Oh, presentation mode. What do you do that? Hold on. I have to figure out how to do that.
Just click on the slideshow, play, or whatever.
Okay, gotcha. All right, ladies, thank you. Are you able to see now? Okay.
I am actually still not able to see, but that's
I don't
okay
see
if
it
everyone else
either.
can.
I see a big black screen.
I could see it fine.
That's so weird.
I don't understand.
Do you have her name?
I see the blue man.
Uh-huh.
Like she
Okay,
was
so
in presentation mode and now you're back out of presentation mode.
Really?
Yeah, I can see like your
let me
aim. Yeah,
How about that?
there you go.
Yes,
Everyone
I don't
see
see
me now?
yes.
Okay. All right, that's a nice workup. Okay, as you know, I'm Audrey Oshry, and I'm presenting an effective use of antibiotic stewardship with the National Quality Partners Playbook in Suburban Urgent Care Center. So the aim is to educate clinicians and patients about appropriate antibiotic usage and to implement antibiotic stewardship clinical guideline practice to reduce usage and increase guideline compliance to 80% by September 8th. The problem is inappropriate usage of antibiotics have yield antibacterial resistant microorganisms globally. And in the United States, antibiotics infection cause 23,000 deaths per year and 2 million illnesses. CDC said that 1 in 3 prescription for antibiotic are necessary, and most of the unnecessary prescription are related to upper respiratory tract infection, which are from viruses. So this is making the problem today is tomorrow. The reason for this, 20 charts were audited between 7 of this, 75% received microbial therapy. But no evidence were available to support 60% of these prescriptions. 20% had received alternative treatment, and another 5% had received watchful waiting. Per the antibiotic guidelines, upper respiratory tract infection, of course, are virus-related. They are self-limited, so you don't need antibiotics, and they are encouraging more diagnostic testing to determine if the etiology of the illness is from bacteria or viruses. The benefit of this would be to reduce allergic reaction and gastrointestinal side effect from exposure to antibiotic, effective antimicrobial therapy, minimize the growth of antibiotic-resistant organisms, and decrease death rate and illnesses. Outcome would be to increase team members' usage of complementary treatment and reduce antibiotic to 80% by September 8th. And this would be the number of charts auditing show this compliance versus the number of charts collected for that review. They have also decreased number of patients requesting antibiotics, and this would be evident through the mean score and the patient survey. The other thing would be to increase appropriate usage of antibiotics to the right drug, right diagnosis, and this would be evident through documentation as well. And the other outcome is to maintain antibiotics stewardship with compliance through auditing and tracking, and this will be done through chart audits, which would be number of charts collected and audited versus the number that's seen that day. The process will be through teamwork. Would rapidly educate the team into becoming competent, and would do the ratio based on the amount of staff trained versus the amount is on the team. Then for patient engagement, we do handouts and decision-making aids, and we'd evaluate that with by the number of shared decision-making intervention versus the number of patients. Then also for process 1, we want to see actual documentation and reason for the antibiotic, and we would verify that by the valid documentation versus the number of patients. And then lastly, we'll do post-clinic audit check, and this we will cross-check with number of audits completed versus number of patients seen that day. I think I missed something back there. Balancing measure would be patient satisfaction, which would be shown at the mean service score, time spent on the project, and patient satisfaction and staff satisfaction. Initial changes will be conducting service simulation, engage patient with handouts and posters, send clinician emails to remind them about documentation, give clinician feedbacks and audits on their performance. Barriers expect would be ego and perceived pressure from antibiotics, patient not returning the survey and decision-making process, incomplete documentation, and reluctance in audit and reporting. Stakeholders will be the patient, 2 physician, office manager, a PA, and 3 MAs. These are my references. Thank you.
That is awesome, Audrey. You came in with 2 seconds to spare. Great work.
Thank you.
All right.
I'm trying to stop this share now and
Yes,
show.
just stop sharing, and then
I did.
And then Karen, you're up.
Cara could see that. Was there anyone else that couldn't see it?
I also could not ever see it.
I could not ever see it. Dorsina, could you see it? Okay, and Karen, could you see that?
I could see it, but I couldn't see Stephanie.
Oh, you couldn't see Stephanie?
Weird.
Yeah.
What about who's using a Mac?
I am.
Audrey, you're
I
using a
am.
Mac. Cara's on a Mac. Dorsina.
No, not today. Today I'm actually on my laptop, which is a PC.
Okay.
Mhm.
Audrey, I need you to go get in touch with IT during the week and make sure, because we can't, in the future, this isn't, we're going to need to be able to see. I have absolutely no idea. I've never had this happen.
Oh, wow.
I mean, I've had it happen where people had black screens and you didn't have proper plugins, but it's weird to me that some people could see it and some people couldn't. So I do need you to work with IT to make sure that that your computer system is functioning at the highest level with the plugins.
Okay, I'll do that.
Y'all see me and hear me?
Yes, we see your screen sharing and we see you. Yeah, there's your presentation. And then if you'll just put it in presentation mode.
I'm ready.
Perfect.
Okay. My name is Karen Reed, and this is my in-game.
Oh, hey, Karin, I'm not able to hear you.
Can you hear me now?
I can sort of barely hear something.
Can you hear me?
Yes.
Can you hear me?
Yes.
Okay. I'm gonna start now. My name is Karen Reed, and this is my in-game presentation, which is on improving the timeliness of quality of life care in fragility fracture patients on an inpatient orthopedic unit. The project is that I would like for 80% of fragility fracture patients who meet the criteria for a quality of life team consult to receive a consult on admission and be evaluated by the quality of life team prior to discharge by September 15th, 2017. The problem that we're experiencing is that 80% of fragility fracture patients are unable to maintain their independence and perform activities of daily living following their fracture, are admitted to a nursing facility, and 20% pass away within a year. And of that 20%, as many as half of them pass away within 90 days of their fracture. Nationwide, there are 8.9 million fragility fractures reported and cost $20 billion in the United States alone. The reason for my project is that at this institution, patients who would be good candidates for a palliative care consult are not being identified early in the admission process. The case managers are currently utilizing the checklist that I'll be using, but they don't always evaluate the patients early in their hospital stay. And once a patient is admitted to the unit, they are typically taken to surgery within 12 hours and discharged home or to a facility within 4 days. The team serves the entire hospital, and they have to prioritize their time and which patients they see. On a recent chart, only 40% of the patients who had consults were actually evaluated prior to being discharged. The outcome of this project is that following it, there should be a new process in place to identify the patients who are candidates for a quality of life team consult during the admission process. Quality of life team more time to see the patients before they're discharged. My process measures will be the hospitalist will participate in staff meetings. We're a relatively small team. It is myself, a PA, and 2 physicians. Easy for 100% of the time that I'm able to either meet one-on-one or have huddles or emails or whatnot to communicate and see if they are satisfied with this process. The hospitalists will also utilize the Where I Stand scales to measure patient care preferences, and I would like for those to also be documented. We'll utilize the checklist that I'm implementing on 80% of admissions, and they will use that checklist to identify patients and order consults within 24 hours of the admission. We'll use the data collected to place the consults, and then the quality of life team will be able to evaluate them prior to them discharging. My balancing measure is I want to make sure that we are not overburdening the quality of life team and that they are not getting more consults than they can handle as they do serve the entire hospital. A large increase in consults, rather just getting them in sooner, but I want to make sure that we're not overburdening them and messing up any other units on the hospital. My initial changes will be staff education, team meetings, huddles, and emails. Be the Where I Stand scale tool. We will begin utilizing the palliative care quality of life high risk trigger and begin entering our consults. The biggest barriers that I anticipate are that the hospitalists may not really want to use the actual paper checklist, and even though it's not part of the official record, They may not document that they're using it. May also refuse a consult since it's so early in the admission. They may be scared and it's an acute situation and they may feel very pressured and they may not want a consult. My biggest stakeholders are the nursing staff, the patients, the clinical nurse specialist, the quality of life team, and their nursing leader, Kay Gruboff, and the physician's assistant that I will be working with in the hospitalist group, the nurse manager and the orthopedic coordinator, Brooke, who is actually already working on this project, and she is helping me quite a bit with it. This is something that is really important to her work with this project, as is the hospitalist group that I'm working with. And there's my references.
All right, great. 45 seconds to go. So good work there.
Karen, are you using a headset?
No, I'm not.
No.
No.
Okay, in the future, you're gonna need to. The audio was very, very, very hard.
Okay. Okay.
And there was a lot of like paper rustling and.
Yeah, it was kind of choppy. So just for future presentations, especially for the final presentation where those kinds of things would be totally distracting, and everything we do is sort of leading up to that. So we'll do this so often that you'll get an opportunity to really be great at presenting virtually well before we have anything like that to do.
Audrey,
right,
you're
so-
still screen sharing.
Oh.
Audrey?
Yes, I just
Okay.
got rid of it. Let's see.
Okay, so let's just talk a little bit about presentations in general. From the presentations that you guys just did and from the ones that you watched, what kind of things did you see that you really thought were great that other students did, or things that, you know, that you think could be improved on, or your own presentation where you think, wow, if I had used that technique that someone else used, that would be really cool?
Oh, can I talk?
Yes, yes, please talk.
Oh.
I mean, I'm good at filling the space, but I'd love for you guys to help me out.
I liked how Karen and Audrey delivered their measurement of change. I found it hard to put it on a PowerPoint, and now I see how they did it, and they did it really well. So I going back, I think that's something that I'd like to work on. They delivered the measurement of change really well, I thought.
Yeah, I have to agree with you. Those charts were really good.
Yeah, I'm like so shamed. I want to go high.
What else did you guys see?
Well, for me, it's a big learning process. So many times I'm thinking like, why did I do online school? Another time, I'm so grateful. I'll be like, if I didn't do it, I would be forced to do some of these things that I have to do. And leaving, there's so much I'm taking away from this that I probably didn't even, in another circumstances, I wouldn't have, literally. One of the things I'm trying to do is to learn, I get how to learn more technology, because like sometimes some presentation, some student, the way they could present certain graphic things, I'm not there yet. So I'm trying to learn and appreciate some of the things that other students do.
Yes. Did you see anything in these presentations that you thought, yeah, I really want to do something like that?
Well, like, who was it? Somebody have some, I'm bad with names. I saw that graphics there where somebody was trying to express, I think it was on maternity, some of those graphics that she was using to express her presentation. Stephanie's, right. So for me, because I'm not good at the graph, I tried to work in that era so I look good.
But Stephanie always has her A game, so don't feel bad. She's always got up on her presentation, so don't feel bad.
Okay. But overall, though, I find it edifying, and especially in some of the maternal things, maybe because I'm not really doing so much maternity thing. And one thing that grabbed me, there was a presentation about the high C-section rate. that we have. And I just wonder for that, if some of that really have to do with not getting enough intervention, or is it more that people want a quick fix rather go through a surgery and be done with it? Are they more happy for surgery more than they have so much problems? I always wonder about that.
Well, Audrey, I think it's multifactorial, but a lot of it has to do with, I want to say that it's a reliance, and things have changed greatly, but I think it's a reliance on this external fetal monitoring, which gives us false reassurance and false information, feeling that, you know, that we need to intervene, when really studies and history has shown that, you know, it doesn't make a huge impact. And then there's also, you know, in certain practices, you know, 5 o'clock comes if you haven't delivered. Some, you know, some people are having surgical births. So I think there's so many different factors to it.
Yeah, I would agree, Stephanie. I think there's, for all of your projects, a lot going on, but that's one that I know well and can agree that yeah, there's just so many factors, but you hit on a big one and you're just going to fix one. And when this goes great, then you'll look at the next one, because that's kind of how quality works, right? You just keep going. So when you've managed this factor, then you'll look for the next one and try to attack that. So let's think about everyone's topics. I'm sorry, your titles, actually. So some people had a title on their screen and some people didn't. But when you think about the titles that you heard and the titles that people said out loud, even if they didn't have it, did we hear the things that need to be in a title, and specifically what, like the IOM 6 aims, like the thing that you're really doing here, the thing that your entire project is going to be about? What did we think about that? Did you hear other aims that you think, oh, that was a really good one that maybe also applies to my project? Or
well, I didn't hear one that would apply to my project in particular, but it was Karen's. I thought it was so poignant, like, and so specific, and I kind of feel like, okay, I probably need to like whittle mine down, get a little better.
Yeah.
It was really great.
Karen, will you tell us your title again? You're muted.
Sorry, I'm muted. My title is Improving the Timeliness of Quality Life Care in Fragility Fracture Patients on an Inpatient Orthopedic Unit.
Yeah, so those big things that we're looking for. What are we looking for in a title?
It was the timeliness piece that caught me, that was like, okay, that's like goes back to the 6 aims, and you really carried that out throughout the whole presentation, and just like the project in general, you took that timeliness from, you know, from when they're coming in all the way throughout. You really tied it together nicely. It was good.
Yeah, Stephanie, that's perfect. That's exactly what I was hoping you would pull out, is that idea that whatever it is that we choose, whatever is going to be that focus, that aim of your project, that goes all the way through. And so if timeliness is an important factor in your project, then your measures should relate to that. Everything should kind of go back to timely care being an important thing. And maybe there are some times where not every single thing relates to it, but it should be a theme that runs all the way through. And sometimes I think that aim, because it's a requirement, sometimes we stick it on the top and sort of forget about it after that. Which aim are the rest of you guys using? Or does anyone want to talk about their aim specifically, whether they think it's the best one for their project?
I think my effective usage for the inappropriate antibiotic, I think that's really, really ideal for that. I think that's the best one for that. Because on the IOM thing, I look it up, and that was what came under inappropriate usage.
Yeah, definitely.
And,
it's kind of exciting when you read the list and you're like, yes, that's the one. Like that encompasses everything I want to do here.
Yeah.
I think also like mine, I probably got to figure out a way to kind of incorporate like the safety measure piece. Although I didn't get to it about the balancing piece because I'm a hot mess with presentations, but about the balancing measure, which really speaks to the safety, because it's a measure of like, you don't want to go too far. You might see increased NICU admissions and things like that. So I think maybe it's taking that and kind of pulling it through that will probably benefit the presentation and the project, really.
Yeah, mine didn't say it, but mine was effective screening for substance use and pregnancy, and yeah.
Yeah, very good. So you just want to kind of look back over your project and kind of see that that runs all the way through. So one thing I didn't really talk about, and we'll sort of go backwards here for a second. Stephanie, when you mentioned like presentation and like feeling like your presentation was, you said a mess. I don't think it was a mess, but we could talk about that for a second. For the people that stayed on track and were within the time frame, within the 5 minutes, what kind of things did you do that you think helped you to stay there?
I went over it.
Pretty sure it comes fast.
I went over it and put a timer at one point, because when I was done, I needed to put all of what I put there for it to make sense. But when I was done, I realized that if I'm not careful, I could go over. So I kind of rehearsed it a little this morning and try to keep within the frame.
What I noticed that everyone did, which I drew from, everyone had their slides and read their slides, like, and tried not to go, over. So especially they read their slides, adding just a few things. So I really appreciate that from Kara's. Dorsina, I saw that you did that, Kara, and like everyone had the same sort of thing where they read the slides, the information was in there, and didn't feel the need to elaborate. Like it was succinct.
Yeah, I usually write out a script and do like what Audrey said. I set a timer, so I'll like write out a script and make sure I have what's included in my slide. And if there's room for stuff to put in after I do my time thing, then I'll squeeze in something here and there. That's usually what I do.
How many times do you think you guys practiced this beforehand? Like those of you who said you practiced.
I did mine like 3 times.
Yeah, I did it about that. I think last night I read it through, some kind of familiar with what's there. And then this morning when I woke up, I was like, threw on the timer and said, I'm going to be timed. Let me try this. So I think I did about 3 times like you did too.
Great. Yeah, that's a theme we actually hear over and over again, is that people who practice it feel more comfortable and stay within the time frame, and people who have practiced timing themselves, so they kind of know, by this slide, I really kind of need to be at this point, or by minute 2, I need to be this far in. Did anybody use a timer of their own during the presentation? You did? Yeah, sometimes that can help too. So it's a good technique to try.
I also might have gotten a little distracted by the timer and had a panic moment when I realized that I was on slide 3 and had a minute left. I'm like, so I think just for future reference, I'll practice it, know that the information I'm presenting is within the reasonable time frame and stick with it, because looking at the timer, it kind of freaked me out a little bit also.
And that's why I didn't. I took my phone, I said I was going to do timer, and I said, no, that's pressure, because I might glance and see the time. So let me ignore that.
I just want to pipe up there and encourage you guys not to do that, because as a speaker, I can't tell you the number of times that I use the timer while actively presenting, because it is only natural that you get up in public and you start adding things because you're nervous, and you'll start the blah, blah, blah. And you have to use a timer while you speak. You have to learn to do that, and you have to learn to not get nervous just because your clock says you have a minute left. It's telling you have a minute left, so you better hustle. And if you don't do it, you can get into major problems. So avoid that temptation. And the other thing I wanted to comment on is just something on this topic that I noticed you guys were doing. This is very natural and easy, and it's very understandable that you do this. I see this back in the PC 713 projects, and then again I saw it here. You're going to be very tempted to stay where you're comfortable and like really talk a lot about the problem and about the rationale. You do this in PC 713 when you're talking about the community. And then when it comes to the budget, it's like, and moving right on. And you see that in the
Everyone disappeared.
Oh, what happened?
Oh no. Oh, there we go.
Is Diana still here?
She looks frozen.
Everybody looks frozen.
Everyone looks frozen?
No, I can see Stephanie and I can see Dorsina moving, and now I can see Karen moving, but I can't see.
Not me either, huh?
No, I can't see.
I mean, everybody's all time.
Nisa, I have not been able to see you since the beginning.
Oh,
Oh no.
huh. Okay.
But I can see everybody else.
All right. Well, that's good to know. I wonder if that happens often. Anyone else? Can everyone else see me?
Yeah.
Okay.
Yeah, I can see Dr. Jolly's is frozen and everybody else is frozen except for you, Nisa.
Like I can see you when you're at the bottom, but when like I try to click, when I click on you to see, you know, when you're speaking, you are like completely black. Your screen is completely black for me, but I can see everybody else. It's really weird.
That's interesting. Okay, I just increased my bandwidth.
Oh, now I
Utilization.
can click on you.
This has been an interesting hangout. We're having some fun here. Yeah, so I definitely appreciate what you were saying, Dr. Jollis. I think that's, I didn't even think about it, but I think it is a natural tendency. And I now that you say it, feel like I probably do that as well. I'll be thinking about that in the future.
I think when I give my, sorry.
Oh, no.
When I gave my presentations, I always had the timer on, but I had the timer on with my script. Like usually I'd try something first without a script, and then I realized that I could talk for days and days. So I had to narrow it down to my key points and then to keep me on track, but also use the timer. So I'd know, like usually before my presentations, I try to get myself at least 15, 20 seconds under to give myself that leeway in case I go a little bit off topic. So I end up right on time or slightly under.
And I want my thought in that too was just to caution you that you do it, that we all do it. We're natural to do that. But it actually applies to your project design. So we're going to force you to format your projects in certain ways that, you know, we commonly see this where the student will say, but I just don't think that way, or I just don't want to write it that way. But trust us that as you move on in your professional life, if you're writing a grant, you will be completely not just unfunded, but not ever even looked at if you don't follow the format. And so when we say problem, national, big picture, shock us, and then we say rationale, we want local data, all baseline data. I know on the IHI form it says lit review, because don't forget the IHI Open School is dealing with medical students who run 4-week projects. You're getting a doctorate and you have your baseline data. So you can't decide when there are rules to just not follow rules or not format it that way. And that's kind of part of what happens is people get comfortable with the way they want to think about it or the way they want to speak about it, which might lead you to not want to go through the measures and talk about the problem instead. So just be aware that it's natural and that you've got to force yourself to follow the plan, and it will work out for you.
Very good. All right, so let's talk through the parts of the presentation then. So what about aim statements? Did anyone see an aim statement they thought was really particularly great? Or anyone think their own aim statement is a problem, they want to share it because they're not because they want to talk about it? Or you believe your own aim statement is fantastic and you want to share that, that's cool too.
I think Karen's was pretty good. I mean, very, to the point, no extra anything. It was just very, you know what she's trying to do. I thought it was good. I thought her whole presentation was really good. I'm still embarrassed.
Don't be embarrassed. You guys all did fine. And that is the whole point of this, is that we're learning this skill. And learning to speak publicly is a skill. It is something that some people might naturally be better at than others, but no one does it well without practice. And everyone gets better when they work hard at it. So you'll all be great at it by the end. We're going to make you do it a lot, so you'll figure it out. All right, Karen, you want to, actually, do you want to go ahead and screen share your aim statement? We can glance at it real quick.
I've sort of been working on this. I changed it just a little bit. I don't know if it's long. I kind of addressed two things. More of the timeliness. That was some of the feedback I got back, was that it wasn't clearly tied to the timeliness. Can you see it?
There, yes, I can see it. All right, so read it for us.
80% of fragility fracture patients who meet the criteria for a quality of life team consult will receive a consult on admission and be evaluated by the team prior to discharge by September 15th, 2017.
And you were mentioning that it doesn't include the timeliness aspect.
I changed it a little bit, so I don't know if it sounds more like it does now or not.
I do like that you said that they would receive a consult on admission, because that does kind of speak to the time frame. Do you have a specific time frame for that?
I would like it to be within 24 hours of admission.
Is that something you're measuring for one of your measures?
Yeah. I'm reworking my measures. Yes, that is something I would like to measure.
So yes, you would want to include that in your aim. Because you chose timeliness as a title. So
Right.
in your aim, you should have a timeliness measure, and then in your measures you should. And it's very measurable, so that's great.
Okay.
Very good. Anyone else have any comments about that?
I wanted to talk about Stephanie's. Did you get feedback on your aim statement, Stephanie?
Yeah, I did.
Okay, what was it?
Let me read it. Let me see. It was, yeah, it was specifically, let me see.
And just a disclaimer, like we don't expect you guys to have incorporated the feedback from your charters into the aim yet. But
No, you just have your charters.
are you having trouble finding it? It's okay. You don't need to. So I just want to make sure everyone's on the same page. These projects end September 22nd. So Stephanie's doing an awesome job of incorporating into an existent movement that's occurring in her hospital. But all of your aims need to end September 22nd. Even though her project's going to go on, she's got to create her DMP charter to end on September 22nd or 15th or whatever. So in that case, in thinking about that, the other thing people, so that's my feedback. And my only point is that in 8 weeks, you may not be able to change the cesarean rate by 3%. So
Oh, I say, okay. My feedback wasn't in terms of, it wasn't in terms of the timeline.
okay.
That was something that you were wondering.
Yeah. So, so aims, so everything Stephanie's doing, so she has a good example of where cesarean is at the highest level. It's going to encompass all of the ramps of her project. But that said, that is an outcome level measure that has, like she said, so many drivers and so many dynamics that it's possible she won't achieve her aim. Now, is that okay? Yes, of course. You're not graded on your success. It's only natural that aids with her outcomes, her aim will be affected. But you're also allowed to pick short-term aims that are at the outcome level. So that's just something you can meet with Dr. Butler about, whether the NTSV is the actual aim or whether you're going to choose an outcome related to intermittent auscultation. But all of you have to have multiple ramps represented in your aim. Did anyone get feedback? Stephanie's is an example where there are multiple ramps represented in her aim. Who got feedback that you only had one ramp represented in your aim?
So think about your aim statements right now then. Do they encompass all of your ramps? Is it something that is a larger overview of the project, or is it something that is kind of focused? Is your aim really the same thing as one of your ramps? Sometimes we see this. And honestly, the presentations go fast enough that that's not something I evaluated. So it's not like I'm waiting for one person to realize I'm talking about them. I'm not. So maybe nobody did that, so that would be great. But if you later on are reading your project and you catch that and you think, wait a minute, my aim is really the same thing as one of my ramps, but then these other 3 ramps are not really encompassed in my aim, talk to your faculty member about it, or try to work it out yourself first, but then talk to your faculty member if you need it. So let's talk about the problem a little bit. So when we're talking about the problem, we're looking for the big picture. We want to see the national data, the literature review, the shock value. I'm sure you've noticed from your charter, from the comments you got back on your charter, that's supposed to be shocking, right? Like, you guys are talking about big problems. Every one of you have big, important problems. Tell me about it. Like, why do I care? What difference does it make if people have their baby by C-section? Give me something that's really shocking. So did anybody stand out? Like, any projects that you guys heard the problem and you were like, whoa, that's a big problem?
Yeah, Karen's definitely, it was shocking and like really sad about like the percentage. And I would be, I don't know what the exact number is now. Was it just people dying essentially from like these fractures that are a preventable thing? That was so crazy to even hear. So that was super shocking. Good job at shocking me.
Yes, that was awesome.
We had numbers about overuse of antibiotics as well.
The overuse of antibiotics, yes. Yeah, those numbers are also
I agree with that
shocking.
one. Yeah, that was a big shock one. Audrey's is the overuse. That was, yeah, I agree.
So then when we go down to reason, I feel like you guys actually got the shock value you got it pretty well, and go back and look at all the data that you know, and you can look at that for yourself and see if you really think you encompass that. But for the reason, this can be a tricky one, because like Dr. Jala said, what we're looking for here, and I think we've been really specific about it. what is the reason that you should do this project in your community? What is the reason that anyone should care about the fact that you are going to do this now? Why do you even want to do it in your community? So what we're looking for there are local data, chart audits. Like, this is where you tell me, yeah, this is a huge national problem, and in my area, we're like failing miserably. Look how bad we've done on this thing. Do you guys all like think back on your own projects? Do you have that baseline data that really says, yes, this is a big problem where I'm at?
I think so.
I believe I do.
Because with the antibiotic, according to CDC researchers, 30% are unnecessary, and they have an aim by 2020, especially outpatient. They think that outpatient prescribe half of the unnecessary antibiotics. So the whole idea is to educate to see if we can reduce some of that. So I think enough data was there. Plus, the chart, when I did pull it, it did reflect the culture of what we're doing.
Okay, I'm gonna be the grumpy mean person and tell you all that you need to step up your baseline data. And one day you'll thank me after you graduate. Until then, you'll hate me and try to get me off these hangouts. But if you don't, you guys are building projects that your project has these 4 ramps. In your rationale, you should have baseline data from your site that supports your ramps. Your patient tracer, your guideline review, your gap analysis, we're all supposed to be building your baseline data. And that's okay. If you don't have a single lick of baseline data at this point in week 9 of your first term of planning, you have 2 weeks left, and we're not asking you to audit 100 charts. I'm asking you to audit 20. And now that you have developing measures and a pretty good idea of what you're trying to measure, I am challenging you to go measure it this week. If you can't measure your measures, you can't get baseline data on your measures, July 14th, you're not going to be able to measure your measures either. So you've got measures that aren't going to work. And now is the time to figure that out. So you've now got your head around what you're doing more. Things are starting to become clear as mud. And I'm begging you to go collect your baseline measures this week on the measures you're trying to propose, so that in the rationale, you're saying, look, we have a gap and here it is. Okay?
Yeah.
Because it doesn't matter what the CDC says. Yeah.
Yeah, it's more than just this is a national problem. You have to be able to show that your people, your area, your hospital, your environment, it is a specific problem for you, and you found this problem because you went and looked at the actual charts. And I love what you just said about if you have trouble going and getting that baseline data now, then you will have trouble getting that data later on July 14th when you're actually going to do your measures. Because I don't have a great analogy for this, but it is just really hard. When you write this out, you think, oh yeah, I'm going to track this and I'm going to track that. And then when you sit down at the computer or at the hospital or at the clinic to try to do that, then you're like, I don't know how to get that. Where is that information? I can't find that in the chart. It's so like, you need to know that today.
So I have a question in particular when I think about my project. When I look and see that many times when antibiotics are given to the patient, the supporting stuff that the guidelines said need to be done are not actually there. So
Perfect.
Wouldn't that be the baseline data? Because that's what I thought. Because the guidelines said you need to say why. The guidelines said if you need to have a basic idea, really, is this viral versus bacteria? And if we're not supporting that, then I'm thinking we're not living up to standard.
Sure,
So
that's
is that
one
on
thing.
track?
It is. That's definitely on track, and it's one really good thing. What I'd encourage you to do, though, is think about every one of your measures. Every
Okay.
one of those things, think through them and figure out if you can collect baseline data on that thing now. If you're
Okay.
talking about, whatever, any one of those things, even if it's the teamwork things, you might be able to say, like, what is team satisfaction now? before we even start this project. That way you know if you've impacted it up or down, if that's a thing that you're going to measure. So whatever it is you're going to be measuring, it's really important to know where you started out.
Yeah, also for patient engagement, you also need to know, how do patients feel about it before you're ever going to do anything to impact that. So if you don't have that piece, how will you really know? If they think that you're great 100% of the time now, and then you do a project and you find out in week 1 or week 2 that you're still at 100%, did you really do anything?
That's a very good question. You know, I wonder about that. If you have to do something that's beneficial, like for example, we always want to know how the patients think about it from now. But let's say, wouldn't I, like, if I'm changing people's behavior, like say you're habitually doing one thing now, don't I need to educate you first, tell you why I need to change it, and then assess, or do I need to ask you from now? Like in the antibiotic issue, where these people already believe that a pill is the solution to their problem. Do I get to see how they feel about the changes first, or do I educate them first?
So what I would want you to do is have that baseline data, because right now you think that they feel like a pill is the solution to their problem, but how do we know that? How do we know that your particular patients feel this way? So when you look at your measures, your patient engagement measure you will have already defined this, how you're going to track patient engagement. So
Okay.
if it is possible, and not every single measure is going to be possible to get baseline data, but most of them will. And if it is at all possible, I encourage you to go out and do it.
Okay.
Yeah.
So I want you,
Couple of times that you work, you can actually ask the patient, like you can come up with some real quick, maybe 2-3 question thing, and ask them how they feel, so that later on, when you actually start your education piece, you'll already know you got data from XYZ number of people, so you can compare that data to whatever's coming later.
so now is the time, like lay out some example of why you can't do this. We'll help you figure it out.
I have a concern about that just kind of brought to my attention, because this isn't just like, you know, I'm working within a larger program. The timeline is a little different. So for example, even something that's small, like I already collected like the staff survey in their comfort level with intermittent auscultation for different areas okay, so that might be measurable, you know, when the survey results, I collect it later when it's done a second time. But for things like a comfort kit, which has little supplies and stuff, and there's a small little card in there about these are things that I find this helpful, did I not, whatever. And then we're collecting them. But the timeline for making these changes, it might be a little bit short. But how am I able to compare these measures on like a small sample when I haven't done the whole, like, the data's not there yet?
Yeah, I can, okay, so this is important for you guys to get your head around. This is next term stuff. So you don't have to completely understand what I'm saying, but you have to kind of get your head around this. Every single measure, so all of you have 9 core measures that you're coming up with in your measurement section. These stay the same throughout your entire implementation. Your DMP charter plan is one plan that you will follow all next term. You will evolve in the little things you do to make it work better, but the plan is the plan, and the plan doesn't change in and of itself, and neither do your measures. So your measures, every single measure except for the team outcome measure, will be measured at least twice a week during your project and mapped on run charts. You guys have already done your run chart IHI courses. You need to go back into the DMP Resource Center and watch some of the completed projects. Every couple days, so Tuesday, Thursday, during your entire project, you're going to be measuring these things. So think about this. You're starting July 14th. July 15th, you're collecting all 9 measures. You've got to think really short term. Get right down to how many patients did I see today and how many got the intervention. Your first PDSA is just you. Don't worry about like hospital-wide doing it everywhere. Stephanie, you may only the next PDSA go just to the midwives, and the entire project you may only be doing focused on the midwifery patients. But you certainly are going to start small and then go big, and you have to, all of your measures have to be able to be operationalized on a run chart to represent a 3-day time period. So throw out a measure that you're thinking. So your comfort kit, you gave out 2 comfort kits that day. You got to get that thing back. You need those cards back. And then you had 2 cards filled out, and you're looking at the data on those 2 cards, and it goes on a run chart. So rapid cycle improvement is not about pre-test, post-test. It's not about doing a bunch of stuff and finding out 2 months later what the outcome is. It's about checking in every 3 days while you implement on a small scale to figure it out. So start where you guys are getting stuck on your charters, take it down a notch, and just think about, how am I going to do this with my own patients next Tuesday? Create it for your own patients next Tuesday. It's going to work for your partners, and then it's going to work for their partners. So I don't know if that answered your question.
Yeah, yes, it did. Yeah.
So I want someone to tell me why you can't have more baseline data in your rationales from your clinic. Tell me one thing you can't put in there, because I am certain we can help you. So tell us now, because these final charters are going to be full of baseline data. Let's hear it, Dorsina.
I didn't hear the question. You broke up a little bit. What did you say?
Tell me one reason why your rationale can't be full of only baseline data from your clinic. I don't want to see any national data in the rationale section of the charter.
Why?
And one data point, it needs to be. I want you to look at your stuff and figure out what measure you can't get fixed by your final charter submission. You need to, it needs to be full of baseline data.
Oh.
You guys threw in one local data point. You have 4 ramps. You should have at least 3 local data points.
I am going to do another chart audit this week, actually. I'd already planned to do that. For my patient engagement portion, because I'm going to be doing the Where I Stand scales, should I look at collecting data on who already has like advanced directives documented because they've already talked about it with somebody?
That would be a great thing to do, yeah. I mean, you're looking at, so you're not going to get baseline data on the Where I Stand scale per se, but you're going to get baseline data on whether the elements of the Where I Stand scale are there. Are the patient preferences documented? So you can look at the last 10 admissions. On admission, were the patient preferences documented, or wherever you plan to hardwire that. Mm-hmm. And then, yeah, were the end of life documents in there? That's all kind of stuff you can audit in a chart. Anything, look at your data measures and figure out how am I going to find that in the chart and collect the baseline. Mm-hmm.
Yeah, some of my feedback that I got was like of the 20 charts I initially audited, 3 had screened positive, but nothing ever happened. It was just like, hey, you're positive. Okay, life's good. So I'm gonna have to try and dig further and see exactly what happened to those 3 patients who screened positive and get some more data off of that to support that huge issue. So that's my next step in terms of that.
Yeah, and just make sure all of your other measures too. Everything that you guys are going to be measuring later on, make sure that you are measuring it all right now. And I'm most excited. I think having the baseline is going to be really great. You'll be excited about that. But I'm most excited that you're going to find where it is really, really hard to get your data, and you'll be able to figure out when something that you have planned isn't going to work, because that's hard. And you can't, like, we'll talk about this later, but I honestly can't stress this enough. Like, the plan has to be so perfect right now. Like, before you go into your implementation, you have to just really, really know what you're going to do, because when you get there, all these other forces kind of are at play once you get there, and people don't want to do it, and everyone's like, oh, why are you making me do stuff that I don't want to do? And you have to deal with all this other stuff. If you don't know 100% exactly what you're doing, how you're doing it, how you're measuring it, like, this is what I'm doing when I walk in the door today, like, it like disintegrates. It's like sand. You just can't even catch it. And it happens so fast. So the more that it feels solid and concrete in your hands today, the better.
What if I mean, I know this isn't really about like whether it, you know, whether we win
Whether
or
it works.
right. I understand that completely. But like with the data that's like so small, what if it shows that it's not working, and like because the data isn't, you know, the volume isn't there, that overall the big, huge hospital picture, you know, it would probably work, but in my small data points, like my run chart is like, "Wah," and goes like down.
Yeah. And you know what it might be? Because when you collect small amounts of data, you know, your chart may just be sort of a big ping pong ball looking thing, and it just back and forth all over the place. But some of the other things you're going to be measuring are things that are going to be good. So you're going to be able to measure how many patients actually had intermittent auscultation. Now, that is still an independent thing on its own. And so if you can show that, look at all these people who had the intermittent auscultation, look at the number of people who were, you know, their risk was reduced because of this, and you can fall back to that national data and say, we know that the risk is reduced when this thing happens. So even if your C-section rate in your small population doesn't make a change, like, that's okay, because you're going to be able to point out these other things that are steps in the right direction, and you're going to be able to say, times 1,000 patients times a year, whatever, this is, you know, we would have seen, and we will see as we continue this project, because all of you are doing projects that are going to stick around long term, right?
And all of these annoying things we're making you do with all the different ramps guarantee that you will succeed and you will fail. So we are like making this little playground where you're going to have success and you're going to fail. And that's what this is all about, to produce the next generation of EMP leaders. So trust us. And I also would say, I just want to point this out because I think your question is like, it's actually really hits on the heart of the issue in distinguishing research from quality improvement. So the person in your environment will say, oh, well, your data is just not perfect because you don't have enough in it. Your N is too small, it's not valid, and da 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 da. 100 reasons. That's the beginning of resistance, of devalidating what you're doing, and of bringing research mind into quality improvement. The reason we don't get anything done in the United States is because people are waiting for the right randomized controlled trial with 100 zillion people. 100,000 wasn't enough. And that's the mentality that doesn't work. But what we're teaching you to do is make small changes on a small scale, perfect systems so that it's reliable, so that the system produces reliability. If you change the culture of birth by having intermittent auscultation as the standard of care for low-risk women, starting with your patients, and create the reliable system to make it happen and then spread it, that change. So this is that your processes, the changes you make in what you do, and how you change the system to do it reliably all the time for 100% of patients leads to the outcome. The other mentality is more of a controlled research. You're already on the point of, we know intermittent auscultation works. You cannot even argue it. And so that's not what you have to prove now. So if you do a small chart sample, it's 20 people, and you got to fix that. So don't devalue the methods you're using by thinking, well, I don't have enough, because it is leading you to valuable.
It made me think about that IHI. There's a quote in one of the videos, the system you have is perfectly designed to get the result that it gets, something to that effect. That's what we're trying to do here. We're trying to redesign the system to get the result that we want, instead of being happy with the system we have getting the result it gets. Okay, so what about our outcomes? The outcome slide, we're kind of looking at the short-term and long-term goal. We want to see big things. We want to see, like, what is the lasting impact of this project? What are we doing here? So, like, Stephanie, when I think about your project and what Dr. Jolles just said, what I'm thinking of is like, we're changing birth culture here, right? We're changing what is considered normal and what is the ideal for low-risk women. What about for the rest of you guys? I think the outcome slides were a little bit confusing this time around. I think there was there was a bunch of information there that you can interpret this a lot of different ways. The word outcome can mean a lot of things. But in this case, let's try to focus it in a little bit. Like we want the big picture of what you're doing here that is going to last, the thing that's worthwhile.
For me, I think ultimately the neonatal morbidity and mortality is pretty much like the big picture.
Yeah, definitely. From those, from, you know, all of the, I guess, the risk that people are taking when they're using drugs in pregnancy. So do you feel like at the end of this project, the thing that people are really going to be left with, like the thing that's going to keep going, will that be that once you've got this screening system in place that more pregnant women are going to be screened, or will be identifying those people and intervening earlier?
I'm hoping that we can like change that culture of mental and change patients' attitudes about feeling like they have to lie and that they can't come and get treatment. And I'm hoping that it'll just be something so normal that they can say, yes, okay, I have this problem. Can you help me? Instead of feeling like they're being judged, trying to change the culture of the staff. It's just normal. We're screening. This is just another thing that we're screening for, instead of saying, well, you probably shouldn't be doing that. It's, hey, you're doing this. We're here to help you. And I'm glad you came in, that kind of thing.
Yeah, no, that really speaks to me, not making an emotional judgment about this thing. I'm so tempted to get off track because like we could have a whole conversation about that right now, but I'm holding back. Anyone else with their outcome?
Well, I'm hoping that people would understand to appropriately use antibiotic. And if for some reason you started a medicine and you had to stop taking it, you know, not to share it or give it to someone else or keep it for later, but get rid of it. Because that's what increase in appropriate usage. So if they get a full understanding, then that ultimately will change behavior.
So is your project focused mostly on teaching patients, or focused mostly on teaching providers when not to prescribe, or?
It's a combination. So we first have provider, and then the provider hold the conversation with the patient to educate the patients, so the patient understand that they don't need it, because it's not just the patient fault or the provider, it's a combination.
Yeah, so those are big outcomes. Anybody have questions about their outcome? Like at this point, sort of lost, like you've been, you know, spinning around in circles, not even sure which direction you're supposed to be going anymore.
So just to clarify, the most common problem we're seeing on that section of the charter is people are telling us their outcome measures. So this is big picture stuff. What will be left when your project, rapid cycle improvement project, is over? Changing the culture of quality, changing the, what are the other big picture things? Standardization of care. Yeah, changing attitude. So the structures left behind, the tools, the confidence, it's not, don't repeat your outcome measures in that section.
All right, I just had a quick question on one of the on my feedback. It seems like I keep transposing the process and the outcomes, right? So just for example, an easy one like teamwork engagement on that ramp. If I'm saying like my outcome measure is that, you know, 90% of the staff will attend the competency day and pass the post-test by the end of the class. And my feedback is that it's a process outcome. So I'm trying to figure out, and then I'm just trying to figure out, I keep transposing that. Like, how do I get something like, how do I word something like that to equal like an outcome if it's not a number like that they're attending the class and they're passing the test and proving they're competent?
Well, let me just, do you want to take that, Lisa?
What I was going to say is that it's a hard concept to wrap your mind around, so don't feel alone in this, but do work on it because it's really important and it has to be figured out. But that the process should lead to the outcome, which leads to the aim. And like your process is the thing you do, and the outcome is the thing that results. So maybe the outcome is going to be that increase in knowledge, increase in confidence, increase in whatever that you're measuring that the staff now have. And then the process is that they came, engaged, did, like whatever it was that got you to the place where you had an outcome. What do you want to add to that, Dr. Joss?
Well, and it's totally unrelated to your question, but I just get like all about. So, okay. Everybody is going to start your project by understanding that you guys, your team is all on the same page, knowledge, pre-test, post-test. So yes, pre-test, post-test are awesome. And you will never hear us say, don't do that. Of course you're going to do it. That's just a way to run a project. So you're going to make sure everyone's starting on the right foot, that everyone's up to date, and it's about super easy, okay? Like, it's not that hard to get a bunch of professionals and people together to be like, hey, here's the latest standard. Did you know it before? Do you know it after? Boom, we're all great. But the big understanding here about why nothing's working in the healthcare system and why we have all these quality problems is that knowledge doesn't translate to practice. So your goal is to take people faster above and beyond the knowledge level of Bloom's taxonomy that NISA has here, and taking them to apply the intervention. And I'm glad, and so this is now skipping into something that Karen had. It's not enough to know something, they've got to be doing it. For all of you who are doing expert ramps where you're referring for treatment, clicking refer is not the end of that expert ramp. Your ramp D has to track the patients who've been referred over time to improve the referral process. Your outcome of referral is that they went. It's not that you pressed click and referred them, okay? So, pre-test, post-test, yes, but that has nothing to do with your core measurement in your charter. Your core measurement are measures you measure over time. You're gonna have 4 data points for anything you're measuring over the entire course of your project on all 9 measures. The only exception is your teamwork. You don't wanna keep doing pre-test, post-test measures on your team. They will be very annoyed with you. It's very offensive. If I was gonna pre-test post you all today and then do it again and again, it's like, enough, you're not a kindergarten teacher. So once you establish people have the knowledge, you're now looking at tracking things over time, like how they're applying the knowledge, analyzing, understanding. But that didn't, your question was the difference between processes and outcomes, and we're now on to pre-test, post-test measures. So because this is a common thing that people are misunderstanding, so we need to make sure you understand this, but then I want to get back to your question, and I know I didn't answer it, and now I'm going to mute myself.
Okay, sorry, I'm having a little trouble getting myself off of screen share. There we go, my mouse is going crazy. Okay, so anyway, yes, I put up that picture of Bloom's taxonomy because I think it really helps to exemplify that for me, that it's not enough for people to know things. It's not enough to just keep pre-testing and post-testing them to say, yes, they know things, they know things, they know things. We all know things. The whole, culture of medicine in America means that we know things. We're not doing things. So how do we get them from knowing it to those deeper levels of applying, analyzing, evaluating, all that stuff? So anyway, on to the process and outcome. Is anyone else struggling with this as well? Like the idea of process and outcome? Yeah, a little bit. So it is really hard, but the process, just always think of the process as the thing that you are doing to create that outcome. And you can measure the process and you can measure the outcome, and you would want to, right? Because if you're going to do a process and it's going to lead to this other outcome, if the outcome doesn't happen, wouldn't you want to know whether it didn't happen because the process didn't get done, or because the process failed, or whether the outcome just failed, like you did the process perfectly and you've got data to prove it was perfect, but that it didn't lead to the outcome? Like, you need to be able to follow those things. So that's why we're measuring the process. Did it get done? How did it get done? All those things. And then did it lead to the thing we wanted it to lead to? Does that help at all? Maybe.
So you guys have to give us examples of where you're getting, like give us the specific process or the ramp you're talking about, and we can help you. Cara?
Yeah, I was just going to say with regard to the process is the steps. So let's say you decide that everybody in your clinic just randomly wants to lose weight. Okay, great. So everybody sets a goal, but how are they going to get to losing weight? Losing 10 pounds is my outcome. But how am I going to get to lose those 10 pounds? I'm going to have to exercise 3 days a week. I'm going to have to change my diet this way, that way. So think about it like in terms of other little things you do, not necessarily towards your project. And then you can maybe turn it around and flip it. Once you understand that, then you can flip it to apply to your project.
I feel like everyone's still looking kind of concerned.
Mm-hmm. So give us a specific thing from your charter that you got feedback on that said, nope, you got the process and outcome wrong, and we'll help you, we'll rework it.
So Stephanie, do you want to tell us yours again? You were talking about education.
But no.
Okay, so I understand what you're saying about like the educate. Let me give you a different example. Okay, because this is an easier one, and I don't understand why it's like screwed up. So the process, okay, is all right. So I had for like the process measure, right? The number of patients who receive a comfort kit out of all the patients, admitted that measured that day. So that's a measurement, right? So what's the process? Like just the process? I don't know. Okay.
Okay. So this is a great example. So she's got this intervention. It's the thing she's doing. It's giving this kit. She believes this kit is going to help these people. She gives the kit. That's the process. I'm giving you this kit. They're going to use it. She's measuring how many kits did I give today? It's Tuesday. I gave 2 kits. How many people qualified for these kits? Does everyone get them, or just you have to anyone who wants natural birth, or how are they getting these kits?
Yeah, you get everyone will get, who qualifies gets a kit. Who's not getting an epidural immediately? Yes.
All right. So any random day, how many people on the unit are going to get one of these kits? July 15th. How many do you think? Just give me an example.
Let's see. Let's 10. That's a good number.
Okay. So 10 people should get the kit, and she's going to measure how many got it. So the process is we're going to get these kits. So 10 people were admitted on the unit that day. They didn't want epidurals. Only 5 kits were given. 5 out of 10 kits were given. That's 50%. July 15th, 50%. Okay, that's a process. She believes this process will drive change. What are these kits? Who cares about these kits? Why will these kits work? When they use these kits, what will happen? You're muted.
So the thought is that they're giving them tools to be able to find comfort in labor, so that they can continue with
what's in this. So give me an example. Where are there birth balls in this kit?
No,
like sniff peppermint oil. What is it? Sniff peppermint oil. So whatever it is, okay, rub your head, sniff pepper. I mean, whatever it is. So,
yes.
So, and you believe that if people use these things, then what will the outcome be? If 10 of 10 people actually used all the things in this kit, what is it the outcome?
So I'm thinking the outcome will be like delayed or no epidural, which I'm hoping leads to intermittent auscultation. That's what I'm thinking.
Okay, so totally measurable, what she just described. She has a tool, it's a process change. People are going to use it. If people use it, they will succeed with their pain relief intention. That is an outcome. So all of these people she told you on a mission don't plan to get an epidural. She's giving them a tool, she's changing the process, and now her outcome measure is a reduction in use of epidural among people who don't intend to get an epidural. So there's 10 people, 5 of them wound up with an epidural. well, actually only 5 of them got the kit. So her denominator is of those who got the kit didn't get an epidural. So 2 of them didn't get an epidural. So it's 3 out of 5, and that's a metric, and it's measurable on that day, and she can track it in the chart, and that is perfect. So that's one example.
Okay.
There's no, okay, so who else is, anyone else? Good. Then your intermittent auscultation is a driver. Your intermittent auscultation can be a ramp in and of itself, but intermittent auscultation is a process change. And if, just like the kit, if they get the intermittent auscultation, then they also should succeed with pain relief intention. No one else? Everyone's totally, they got it. Why is everyone quiet and worried?
I would like you guys to know that, like, the intention of this to me is that we make this space as safe as possible of a place for you to just put out your ideas and your concerns. Don't feel like there's no measurement of this. Your grade does not change because you knew all of this before you walked in here or because you didn't. I just want you to feel as comfortable as possible to say what you're really thinking, because there aren't that many opportunities to really get feedback directly from faculty like this. And you can call, you can set up appointments, but you're going to get 30 minutes of my time, and it's not like this where you're getting all of these eyes, all your classmates' eyes, everybody's eyes on your project. I want you to really take advantage of all of this. So let's keep going with the measures then. So we understand process and outcome a bit now. Oh, one thing I wanted to clarify, because I've had 2 questions about this so far in the sessions that I've done, and it's something that, probably everybody already knows this, but just in case there was anybody out there that didn't. I really want you all to understand that the A, B, C, and D ramp, those are the 4 ramps, right? Those are the 4 things that you are doing for this project. So A, B, C, and D, you're going to do all 4 things on the first day of the next term, July 15th or whatever day it is. You're going to do A, B, C, and D, and you're going to keep measuring A, B, C, and D every cycle. And the cycles are the every 2-week thing. So we're going to be, and that we're always going to use numbers, because this whole thing's confusing. So if we always use letters for the ramps that we're doing and cycles and numbers for those cycles for the 2-week increments, it keeps us all from losing our minds and not knowing what we're talking about. So A, B, C, and D, you're going to do all of them at the same time. Sometimes people feel like they're going to do the staff team building exercises, and then they're going to do the patient engagement, and these things do not happen separately. You're going to implement them all at the same time, and then every cycle, you're going to do the whole thing. The plan, do, study, act, you're actually going to do that. You're going to watch, look at the data, all that stuff, and figure out what you need to do differently. Maybe nobody used your form because everyone hates your form and they want you to make it shorter, so you make it shorter. Or maybe nobody notices your patient engagement tool, so nobody uses it, so you have to make it bright orange. Or whatever. Like, these are the kinds of things, those tests of change, those little changes you're going to make along the way. And probably you all got that because nobody's saying anything, but just in case, it's out there.
Yes, yeah, that's clear.
Good. Good, I'm glad. Okay, so any other measures that you're concerned about, like just where you're not sure about the process and outcome, or you're not sure that your measures really all relate to your aim, or anything like that? You're not sure that all of your measures relate to the IOM 6 aim that you've chosen?
I guess I need to fix my measures so that I include timeliness, or include my time frame. I need to rework that.
Yeah.
But sure.
So actually, in looking at yours, I was thinking, because you had refer.
But I didn't all the way work.
Yeah, so what you can do is, like, for your D ramp where you're referring, you can look now at what your baseline is from when I'm currently referring.
That's what
to
I'm
now. Yeah, and then you can decrease that by 24 hours, or decrease this. It's called cycle time when you refer and then complete the referral. So you can decrease cycle time by 25%, and that's just a mean. It's number of days, number of hours, whatever it is.
And then, so my one can be number of days when the consult's placed, and then I also want to look at who's evaluated before they leave, so what day they're actually being evaluated on? Like, you see what
Can
I'm
you
saying?
pull, if you screen share your measures, it'll be easy for us, easier.
While she's doing that, just wanted to make sure everyone is clear also that we need to be able to measure both the process and the outcome. So your outcome also has to be operationalized in a way that you're going to track and put on a chart and have numbers for. There was one presentation, I don't remember which one, that didn't have the operational definitions for the outcome, but did have it for the process. I just wanted to make sure no one was thinking that. Sometimes people think that that outcome is something you measure only at the very end. It's not something you have to track all the way through, but you track it all the way.
Can you see my slide?
Yeah. This was a nice, Karen did a really nice job. So I wanted to, I want to point this out, and so this is just a, a learning moment, and everyone is going through this. So on the B ramp that she has, she's using a tool, a shared decision-making tool. And for all of you, as you approach your B ramps, I just want to be really clear, because this is an area where I'm not sure why people are confused, but people are confused. Now, Karen is not using an SBIRT. Are you using SBIRT? Yes, she's using SBIRT.
Yes.
A lot of you are using SBIRT. That means it's screening, brief intervention, referral to treatment. And what's happening, I think, as people are designing their project is they're a little bit confused about what the B ramp is. In an SBIRT framework, the B ramp is what you're doing for every patient who screens positive. So if you're screening for drugs, depression, infections, or a desire for natural births, whatever it is, when someone screens positive, a brief intervention is the B ramp. And if you're using a decision aid, you really got to look at that aid and really understand, like, those aids are completely measurable. And someone else brought this up, and I can't remember who it was, about this question of oh, Audrey, you brought it up. Don't we have to educate people? Don't we have to tell them stuff? That's true. And if you go into the teaching module on patient preferences and on the education piece of the evidence-based practice queue, there are evidence-based teaching standards. When you're teaching a patient, it's called motivational interviewing, shared decision-making. There's all kinds of education frameworks, but the principle is first you make sure they have the knowledge. So you give them the facts. But we're not asking you to give them the facts and have them leave. We're asking you to have a deep level of engagement with a few patients. Some of your B ramps may only be with your patients. It may not be with the entire unit. But when you engage deeply and in accordance with evidence-based practice, yes, you provide them the basic facts. And then you give them a coordinated, organized options grid. You can do this or you could do that. And it gives facts about what happens if they do nothing and what happens if they choose to do this. Then it has a piece of gathering the patient's value system. And it's an organized, evidence-based way to understand what does the patient believe and what are their preferences. In the end, you have a decision. And you can actually track how the patient's values affected their decision. So yes, you know they have the knowledge, you know they understand their decision, they document their preferences, and then their care is related to that decision. That's the process of shared decision making. So when you use a decision tool, you gotta read the decision tool. You gotta really look at what's measurable there. And then I would argue that your outcome for that is in the tool itself. It's one of those measurable outcomes. So when I see outcomes that aren't linked to the guts of a tool, I'm concerned that you aren't reading the guts of the tool. So that's just a note on decision making and engagement. Okay, so how can Karen take her, she's got, for her C ramp, it's all about using a checklist to drive change. That's her process. You know, it's not fine to say, hey, we're gonna try to increase these quality of life consults. How are you gonna try to do it? What process are you gonna change in how you're doing things? Oh, we're losing her. So she had, this checklist was gonna drive her changes. I can't see you anymore, Karen. I don't know if other people can.
Can you see me?
You're a black
Oh.
screen. I don't know what happened.
Yes.
Can you see? I stopped screen sharing.
Now you're a black screen.
I can still see her.
I can see her.
Weird. Okay. So in further reinforcing like the process of, she wants to make sure these consults happen within 24 hours. It's not just going to happen. You don't just tell people, hey guys, do this. She's actually going to change the workflow to make sure that it is done, because she's going to facilitate figuring out, why is this workflow not working? So she's analyzed this. She's decided a checklist will help. That's a process change. They don't currently have the checklist. Now they're going to do the checklist. So her measure, can you see? I don't see you. You're not screen sharing, right?
No, I'm not. Let me screen share. There it is.
Do you guys see it?
I can see it.
Okay, I can't see it, but her measure is that they're going to use this checklist, but what's the outcome? So how can she fix this outcome to make it a timeliness measure?
Are you trying to get the answer?
I'm trying to think back. It'd be really nice if I was able to figure this out, because then I would understand the difference between the process and the outcome. So I'm thinking like the outcome.
She has an outcome. It's not the wrong outcome.
Right.
But how can she shift that outcome to be a timeliness measure?
That it occurs within.
Wouldn't that be getting as much patient as she can assess within that time frame that she wanted, versus the amount of patient that's actually came in that day?
So that's a good point. So that's a metric that she could use. That's the number of patients who had completed their quality of life visit with the referral over the number of patients seen that day. But for her timeliness, how are you measuring time?
The number.
If it takes longer time to, for timeliness, maybe if it's taking more time to complete all of this than it normally would of the system, I don't know.
Yeah, so
I
these
think I'm
things are
confused.
usually, okay.
I mean, I thought, you know, when you're talking about timeliness, I thought she had it in there when she's talking about within that 24 hours of admission thing. Is that wrong? I'm confused.
Does your outcome measure on that? I can't see your stuff. I have no idea why, but I don't see I see a black screen.
Outcome measures. One of her outcome measures says within 24 hours.
So I'm asking about her C ramp outcome measure. What does it say?
Yeah, that's my outcome.
Yeah, that is the CRAM.
Yep.
Placed within 24 hours
Yeah.
of admission.
That's a process. So your process is that you're going to start referring people. How do you know that there's so you're screening everybody? Is the checklist the screening tool to know if they need it or not?
Yes.
Okay. And then your C ramp is that I thought I can't see your thing anymore. I thought it said 80% of people will have it done before discharge.
That was my C ramp was to use the checklist, and the result was that the consult will be placed. My D ramp was that the consult will be done before the discharge. Like the follow up.
Okay, so how do you measure that the C ramp? So you can do 24 hours. Was it measured yes or no? You can also do, I mean, it's just hours. It can be mean. It could be, this was placed within 5 hours of admission. This was placed within 24. That's timeliness. So she's counting time. So you have time there.
Okay.
Any other questions about that?
So how can you move the D ramp to be a timeliness measure? It's besides before discharge. Is there something else you could do to be timing related to minutes, the mean time, the mean cycle time?
I guess the average time it takes them to actually see a patient, 1 day, 2 days, 24 hours, 48 hours.
Right, so that's just a mean. On any given patient, you can see exactly what time, you measure time. And then you can try to decrease the mean time from 48 hours to 12 hours or wherever you want it. But the two things can't, yeah, that's.
So did that help, Karen?
Yes, it did. Thank you.
Good. Anyone else want to talk about some of their measures real quick? We just have a few minutes left and a few things to talk about, but what about balancing measures? Does everyone understand the concept? Like why do we care about balancing? I think
For
of
my
balancing
balancing measure. Oh, sorry.
No, go ahead.
I was just gonna say for my balancing measure, I had like hold on, let me pull it up. Basically, it was more like a time thing that it wouldn't take, X amount of time when I implement this process, that the time from when the patient arrives to when they leave the office, that the time wouldn't be impacted so significantly. So that was one of my balancing measures.
Yeah, have you been able to get baseline data on that yet?
Pardon?
Have you gotten any baseline data on how long patients are in the office right now?
No. I haven't actually tracked from when they arrive to when they leave.
Okay. I think that would be an important thing to have for that balancing measure. You could find out exactly how long patients are in the office right now and then see if there's a difference afterwards. And then you could maybe assume that this is going to take a little while. Like you could give yourself some time.
Yeah.
But maybe say it's not going to increase more than whatever.
Okay.
And just a note on balancing measures before you guys go down the road of it being complicated. For all of your measures, you want the simplest thing to measure. What is already being measured at the site? Use it. So if your site has something, where I work, when the patient comes in, there's a timestamp, and when they leave, there's a timestamp, and the computer with the click of a button can tell me what the average cycle time was. That is a perfect balancing measure. I don't need to know, wait, was it this patient? Did they receive the intervention or not? And how can I only measure those who had the intervention? That's too complicated. For a balancing measure, just did you throw off the balance of the entire clinic by your intervention? So if the mean cycle time didn't change over the course of the project, you're fine.
I just have a question. So if I'm wanting to determine how this implementation is affecting the staff, whether it's annoying or just adding more burden to them, can I just do like a survey to measure?
All right, Cara, are you there?
Hello?
Unmute.
You're mute. Okay. All right. So tell us how annoying it is to constantly, what advice do you have to them about how to check in with your staff?
Listen, like our clinic was overkill. Like we had every Monday they had to watch a Monday video. That could last anywhere from 5 to 10 minutes. That was every single Monday. Every single Thursday, you got a Thursday email. So when I started doing my stuff and I started sending these emails, everybody's like, I am over it. I don't care about your project anymore. Like, stop sending me all these emails. Stop talking to me. So your staff is going to get aggravated no matter what, because they're not used to you asking something every 2 days or every 3 days to get their opinion. So you're going to have to sometime in the process become creative in how you ask them the questions. I stopped sending emails. I stopped sending them surveys through emails. I would like just talk to people randomly and ask my questions that way and record their responses, because it was easier than them sitting down and having another thing to do.
Okay.
Another good way of thinking about balancing measures can sometimes be thought of as the thing that the nastiest, oldest, unfriendly to change person in the office is already going to be saying about you. So the balancing measure is going to be like when that person is like, oh my gosh, you know, Nisa's always asking for this and that, and it's so annoying. And, you know, if we reduce our C-section rate, we're just going to have more babies being admitted to the NICU. And, you know, we're just going to be like, this is terrible. This is a stupid plan. And so whatever it is that person's going to say, your balance can always just be the thing that you would use to refute that. Like, oh, look, we decreased our C-section rate and we didn't have any more admissions to the NICU, you know, whatever it was. It doesn't have to be that, but if you can't think of anything, this is a nice way of thinking about it, because somebody will be complaining about something, because when you make changes, people do complain because they don't like it. So you can always think about what that thing is that people are already going to be irritated by.
I have a question. In terms of when we're doing our balancing measures, what is acceptable that you would consider your intervention, especially when you take a little bit more time or something to that nature? So what's acceptable as this is too much, or this is just a little bit, so it's okay? Is there a percentage margin that is would say 2%, 3%, 5%?
It's really going to depend on your environment and your clinic and what people are willing to tolerate. So yeah, if you show that, you know, the amount of time that was spent with patients increased by 10%, by, you know, whatever, it did actually change that a little bit, then you can say, but look at this outcome. Look at the fact that we did this great thing. Isn't it worth 2 extra minutes, you know? So sometimes it is worth it. And sometimes it's not. I don't think we're able to say, like, you know, this many minutes.
Gotcha.
But your clinic, Audrey, in urgent cares, a lot of urgent cares already have a time thing in place. Like for most urgent cares, you want everybody in and out within 60 minutes. So your clinic is probably already measuring those things. So right now, let's say your average time in clinic is 35 minutes. If you're about to implement a tool and now your time goes to an hour and 30 minutes, okay, that is significant for your clinic, and nobody's gonna like that.
That's ridiculous, right? Nobody will come back. Yeah.
So you just have to like make it something reasonable that, you know, you can still look at your clinic site. So everybody's could be completely different. What you measure in urgent care could be completely different what somebody else is gonna measure in, you know, somebody who's giving birth or
right,
something different.
The other obvious thing that you guys are already collecting is your time log. So you have a track of how many volunteer hours you've spent on this, and that's a balancing measure, because you are achieving quality and you're improving things, but the side effect of it is that you're spending a lot of time. That's not compensated, so that's a negative impact of a positive change.
Right, that kind of goes to sustainability. You know, if that's going to continue, if you have to put in 20 hours of your own time every week in order to make this project successful, that's worth paying attention to, right? Because how long are you going to do that? Are you going to commit to that for the next 5 years? Yeah, probably not. So you want to make sure that it is worth tracking, so you can see how do we work these things in so that they become sustainable on their own and not require 20 hours of your personal effort to make them happen. So we just have a few minutes left, and we did not really talk about initial changes. And this is another place where I see a lot of people getting confused. The initial changes are those things that you're going to do right away, the things that you're going to be ready to do on July 15th, right? Yeah, whatever day it is. The things that you are going to be like, I'm ready to implement that day. And there should be something for each ramp, right? You're implementing all 4 ramps, you're going for it. Did anybody, I don't remember from all of your presentations, anybody have any questions about that?
I thought Karen's, and these recordings are going to be posted on the sign up sheet so you can go back and watch each other, but Karen did a really nice job on hers of highlighting, and I'd have you show your screen, but I can't even see you, and I definitely won't be able to see your screen, but maybe other people can see it. But for whatever reason, this is getting lost. A, B, C, D on that section in the charter. You must read the charter guide. You cannot pass your final charter if you have not followed the instructions on the charter guide. So we want to know what is happening in your ramp A, B, C, D under interventions. It's a bullet point. Karen did it awesome. So the thing is, the next place you'll get stuck is it's not your measurement. It's what actions are you taking? The actions are that thing you do to make process changes to the process outcomes, and the process outcomes lead to the outcome. So what are you doing?
Anybody want to tell us something that they're doing? Somebody tell me what you're doing for your ramp C. What is your initial change?
I'm doing it.
Well,
Oh, sorry.
I was gonna say my ramp C is the there's this SBIRT application that you can actually install on a tablet or whatever, and it pretty much it prompts you. It's like a script of how to interview the patient when you're screening for the initial screening for substance use. So that was my CRAMP.
So what is it that you're doing? What are you going to write in that blank? You're going to have to write
what do you
down
mean,
the
like my?
So
Yes. Yeah. So the initial screening is done by the intake nurse. So my first like get together would be with just the nurses and them downloading that app onto their phones and following the script from the app.
So for CRAMP, your initial change is going to be that every patient is screened by the nurse on admission with this SBIRT.
Yeah, at their new OB intake visit, every new OB patient is screened using the SBIRT app.
Is there already in your electronic health record a place where they have the screening?
It's basically just like radio buttons. If there is drug use, if they smoke or stuff like that, it's in that Epic, on their chart. But it's not, it's not detailed. It's pretty much, you don't know how the question was asked. It's just, what they use and how often they use it is all that's there.
Okay, anybody else want to talk about an initial change?
Initial change that I'm using is it's a simple tool that we developed. It's IA appropriateness checklist, and it's just an easy tool. It has about like I want to say maybe like 10 little portions to it. Maybe not even 10. I think maybe eight little pieces. And if a patient qualifies, it's yes, no, not time consuming. And if a patient qualifies for it by everything in the yes column, their appropriate gestational age, their vertex, their singleton, they don't have these interpartum issues that are specific in the list. So that's the first thing that we're gonna implement. I'm gonna try to, at least anyway.
So when you say that, what I'm thinking is maybe really specific. Like those checklists are going to be placed in each chart, and the nurse is going to do that immediately on admission? Or like, how is that going to happen? I mean, I just made that up. Is that how it's going to happen?
That is how it's going to happen. Yep. That is how it's going to happen, like part of it. And part of that IA checklist is going to be face-to-face handoff. So part of the flow of the patient flow is from triage to labor and delivery, or from triage to the antenatal unit. So part of that bedside face-to-face handoff is going to include what we have now, which is an SBAR sheet, and the IA appropriateness checklist, so that there's no miscommunication on whether a patient is appropriate for IA or not. So yeah, that's part of it.
Very good.
Just to clarify what Nisa was pointing out, so that it's under, like, so that we're 100% clear with everyone. If on your first intervention, you're going to say, I'm going to use this tool. I'm going to use this checklist. I'm going to use this algorithm. I'm going to use this, whatever. That sounds fine. But what we're trying to nail you down on, you don't just say on Tuesday, I'm going to start using this, without doing something different to make yourself use it. It's a behavior that you're doing. And so on that section, they're asking you for the exact things you're going to do differently to make sure that thing gets used. It's not enough to just say, I'm going to use it. You got to think through, well, how will I make sure I do use it? Now, again, your first things can just be with your patients. So it's okay to think about it that way. You don't have to, your teamwork stuff, you do have to launch the project in the group, but whether everyone does every piece of your project, they're not required to. There should be aspects of it that the whole team is around, and your team is individually defined by your site. So your team might be your MA and your front office, or it might be the entire unit or the entire hospital. Everybody's team is different. But I don't know if that makes sense.
It makes
about
sense.
the actual what you're doing.
That makes sense, but I'm wondering if part of the process change is, identifying why, like you said, if the checklist isn't working through the process, making it orange or whatever. Is that part of the change?
Yeah, so that's what that plan, do, study, act. Like when you get to the end of, or the middle, probably, you're checking data every 2 or 3 days, and you're like, I mean, I gave out the checklist, like everybody had the checklist, I told them to use it, and it got used 2 times in the whole, like, what am I supposed to do here? How do I fix this? And that's what, that's that evaluation. So then the second PDSA cycle, when you're figuring out, or at the end of the first PDSA cycle, you're submitting your paperwork and you're telling me, what is your change? What are you doing? You are going to change that form so that it is shorter, so that it is less cumbersome, so people actually use it, or you're going to make it a different color, or you're going to make sure that it's put into all the packets so that when somebody pulls a chart, it's already there. They don't have to look for it. Or maybe you're going to add it onto the SBAR sheet that's already there, so that they already, like the form they're already used to having, they'll just continue all the way down it, or whatever. Like you're going to figure that part out. But those are the kinds of things that you're going to be writing for us each time. Like after you've evaluated this first cycle and you're going into cycle 2, you need to be able to tell me, like, what are you going to do differently for ramp A, for ramp B, for ramp C and D to make them better, to make them happen if they're not really happening, or to if they're like, maybe they were 100%, maybe everybody loves it and it's great. Then what are you going to do? You're going to just sit at 100% for 4 cycles? No, you're going to say, okay, great, let's spread this on. Like, then now another provider is going to start using this.
So essentially it's okay, right? It's okay, like that it's not like a perfect thing right now.
Yes. I just need to know that you know where you're going to start. And I think it sounds silly. Like, of course you know where you're going to start, right? You already said you're going to give the nurses these things and they're going to start using them. But sometimes when you actually get there on that day, little things that don't seem hard right now will suddenly seem hard. Like, where are all the forms kept? Are they kept at the nurse's station? Is the nurse supposed to pick them up? Or are they already in the charts when you got there? Or, like, those kinds of things that don't even seem like actual things today become really big obstacles. Just trust me. No, I'm sure you guys, like, I'm sure you hear what I'm saying, but I feel like it is all so much more confusing when you get there. So if we can make it easier, I just want to make it as easy as it can be on that day. All right, so the only thing we didn't really talk about was barriers. Just be sure when you're talking to us about barriers, when you're writing them on your PDSA form, and also just for real life, for practice, that you are really think about the barriers. Think them all the way through. Figure out what you're going to do when, you know, the night shift nurses band together as a coalition and declare they will not do this. Think about what you're going to do, whatever the thing is. You know, you can kind of see what some things might be, and sure, somebody's going to throw something in you didn't expect, but spend the time now, figure out how you're going to jump around the barriers that you know about. I've already kept you guys 7 minutes over because apparently I didn't time myself. So, do you guys have anything else? Anything you want to say or whatever? Just want to be separate. Okay.
I will just reiterate that if you're struggling, you have continuity faculty advising. And the process for this is you have to figure out your ramps before you can figure out your measures. So you have to have a very clear idea of what am I doing to build my team? What am I doing to engage the patient? And what am I doing for process change C and D? And until you have that solid in your head and you have thought it out, act like you're doing it, you're gonna do these things on Tuesday with your own patients, then you can move on to the measures. And yeah.
All right. Well, thank you guys for coming. I thought it was fun. I hope you feel like it was fun and useful too.
Yes, it was. Thank you.
Thank you.
Good.
Bye,
Thank
guys.
you.
Bye.
Good
Bye.
luck. Let us know if you need anything.
Will do. Thank you.
Yeah.
Bye.
Bye.